You're listening to The Q Switch with your host, Spence.
Welcome, one and all, to the Q Switch Conversations podcast. I'm your host, Spence, and the mission of this show is to tackle subjects currently impacting ophthalmology, where we invite the innovators, thought leaders, and forward thinkers shaping the field of ophthalmology to discuss their unique perspectives. So let's jump right in. Today, on the Q Switch Conversations, we're joined by someone whose name quite literally sets the tone for her entire philosophy of care, Dr. Aliona Radzindsky, better known to her patients and colleagues simply as Dr. Rad. And trust me, the name fits. Dr. Rad's journey into eye care started long before she ever stepped into a patient's home. She graduated cum laude from University of Southern California, earning a Bachelor's of Science in Health Promotion, a foundation that clearly foreshadowed her passion for bringing better healthcare directly to people who need it most. She went on to complete her doctorate of optometry at Western University of Health Sciences, where her commitment to service and patient-centered care only deepened. After launching her own practice, Rad Eye Care, in 2017, Dr. Rad didn't just build a clinic, she built a vision. And in 2020, that vision hit the road, literally. She founded Rad Mobile Eye Care, a fully mobile eye care service designed for patients who can't easily get to clinics or who simply prefer the comfort, familiarity, and low-stress environment of their own homes. Since then, she and her team have brought comprehensive eye exams, bedside evaluations, and specialty care to hundreds of patients, including seniors, those with limited mobility, individuals with dementia, and anyone who benefits from care that meets them exactly where they are. She's a clinician, an entrepreneur, a problem solver, and a trailblazer in a growing corner of optometry that's redefining what access to care really looks like. So buckle up, or should I say, start your engines, because today we're diving into the world of mobile eye care with the one and the only Dr. Rad. Dr. Rad, great to have you on the Q Switch. Welcome to the show.
Thank you, Spence. Thank you for having me.
Hey, so Dr. Rad, it's truly wonderful to have you on the Q Switch Conversations. I just shared your background, and you've had quite the compelling journey up to this point in your career. Before we dive in, could you tell our audience a little bit about your early path, specifically the why behind choosing optometry and how you got into mobile eye care?
Sure. Optometry was actually a field I went into as a teenager. One of my first jobs, answering phones at an optometry office. I immediately loved it. I saw what value eye care brings into people's lives. And I went to undergrad with that idea and never changed my mind. Graduated USC, like you said, in 2010, went on to optometry school. And the mobile business was actually a COVID baby, which I'm sure we will get into.
So from that beginning, I'd love to talk about the genesis of your mobile model. What was the moment or insight that made you think this mobile eye care model is something I want to build? That unmet need, what unmet need did you see, especially for patients who have difficulty getting out or prefer in-home care?
Yeah, so like I kind of mentioned, this came about during COVID. Before COVID, I was very busy working in my practice. Mobile eye care was something I thought about for a long, long time. I had a grandma that was in an assisted living. I saw all the avenues of care that she had at her disposal, and there was no one doing eye care. And it was really hard to find anyone to take care of vision or anything eye related for her. So it was kind of something I always thought about, but the wheels were turning at work and there wasn't much time. Then COVID came along and we
Then
all
you had plenty of time.
Exactly. So that's kind of where I really dived into it. I had actually a patient at the office that I had put on glaucoma medications the day before we all closed. And him and I had a good relationship. He'd been a patient for many years. And, he contacted me saying, what do I do? I can't go to your office. It'd been a few weeks. Tonometry is actually a pretty easy test to take with you wherever you go, very portable. And so I said, if you are okay with it, I can come check your pressure at home. We can do this house call style. And he said, let's do it. And I did it. And after that one time, I was like, I can do this. We can figure this out.
Nice.
Here we are.
Nice. So let's unpack that undeserved population a bit more. On your website, you mentioned special populations, bedside exams, dementia-friendly care, assisted living communities. Can you describe the types of patients that you serve with Rad Mobile Eye Care and what unique challenges they face and why traditional brick and mortar practices may not always be meet their needs or be the right fit?
Absolutely. I would say vast majority of my patients are elderly. They tend to be the ones that have harder time getting out for care, might be mobility reasons. We've had patients come into the office where, they're older, their posture changes, their neck can't get into our equipment. It's hard to perform an exam. They struggle. They sometimes struggle even getting out of their beds, out of their homes for any kind of care, let alone eye care. So definitely are a huge community in need of mobile services. I also have a pretty big contingency at this point of homebound adults. So there's adults that for various reasons are bedbound or homebound, things like MS, cerebral palsy, even I've had adults with just phobias. They can't get out.
Really?
But they're home and they are very much in need of their vision because they're usually home on their computers all day. A lot of them work. They're still in the work field. They're just working from home. So they definitely need their eyes and they're a big chunk of our practice as well. And then the smallest piece are just, our concierge patients that choose to have eye care come to them for convenience.
Fully healthy, just rather have you come to them. Okay. So shifting to the practical side, when you go into someone's home or assisted living facility versus seeing them in your office, what are the major differences in how you treat the patient, from logistics, patient interaction, equipment, flow, to overall experience?
Yeah. So I think it's actually very valuable to see a patient in their own environment. Common examples, I've had patients where they tell you over the phone, I need the doctor to come help me get computer glasses. When I come there, I realize that their computer is projected onto a screen 20 feet in front of them across the room. So little things like that, when you're in the environment where the patient is, you see exactly what they need in terms of glasses, solutions, if glasses are even a solution. You can see how exactly they're using their eyes and what their needs are. So
Hmm.
I think something that doesn't always translate into the office. In the office, they all sit in the same chair, look at the same chart, and we assume that everyone's TV is across the room and computers up close when it comes to prescribing glasses, but not always the case.
Well, I would think that would be an advantage in your case because, again, you see them in their real world working environment, how they actually use their eyes on a day to day, distinct advantage. I mean, much like when everyone's great in the lane, but once they walk outside your door, you have no idea what they're doing or how they're using their eyes. And so you kind of flip the script on that, and you've, been in their environment and able to see exactly what's going on and how to best treat those folks. That's, again, I would think, a distinct advantage for you.
Definitely, definitely.
So any new business model has hurdles and wins. So what have been the biggest challenges you've encountered in building and running the mobile model? And on the flip side, what have been those standout successes that validate the model for you and your team?
So it was very much a skill set that was something that came about with experience. In school, we learn a lot of techniques, of course, but I would say what I do today in mobile eye care was very much a project of learning as I go. A lot of equipment that I use today, I didn't have in the beginning, or I bought things I thought I was going to need that I realized don't work well. Perfect example here. One of the first kind of mobile tools I invested in was those virtual reality visual field tests. Seems so portable, and I do still use them. And there's definitely, again, a demographic I can use them on. But the biggest chunk of my patients, the elderly, they can't do that test. It's just not happening. The VR thing is confusing. Their posture might not allow for proper placement. So that was just kind of one of those learning curves, really understanding what equipment I can use on what patients, what I cannot, and modifying. Some things that I use come from pediatric ophthalmology. They
Wow.
work with patients with dementia that are nonverbal or can't articulate. That's really the biggest thing is in the office, I would, again, comparing office to mobile. In the office, we have our toolkit and everybody gets the same testing more or less. In the mobile practice, I have a bigger toolbox and the tests I do and the technique really has to be adapted to the patient because checking a 99-year-old with advanced dementia versus a completely cognitively non-impaired adult that's at home and needs glasses for presbyopia to do their job on the computer, two different, completely different ball games.
And so you started out with basically no tools, kind of what you thought would work. So it was kind of a test and learn process for you? And so, about what point in time did you really feel you had all the necessary basic fundamental tools just to go in and perform a routine exam or an eye check or be able to treat somebody?
Yeah, so it's funny. The first mobile eye exam I ever did, I think I spent 2 hours with my patient. I was everything
Wow.
manual. It
Good thing
really
good thing they were at home.
yes, exactly. It really felt like being back at school. It was just trying to figure out how can I get this data? Okay, that test didn't work. He's not able to do this test with me. How else can I get this information? It was a big learning curve. Today, 5 years in, I feel confident. I can pretty much handle whatever we encounter in the mobile world. And that's the thing about the mobile world is every patient is so different and everybody's got different needs. Um,
I can imagine. Now, from a scope of practice vantage, how does the mobile eye care model integrate with co-management relationships with ophthalmologists? For example, when you identify something that needs surgical or ophthalmic management, how does the referral slash communication work, especially when you're outside the traditional clinical setting?
Yeah. So it's super important in the mobile model. There's a dichotomy here. So in my elderly patients, honestly, by the time they get to me, they've generally either had, for example, cataract surgery. A lot of patients have already had it. Or if they haven't, they tend to be at that point in life where it's too hard. I mean, if it's too hard for them to get to my office for an eye exam and they're choosing to have a mobile eye care, sometimes surgery just feels off the table. For logistics, they might need gurneys, they might need medical transportation. It's not as easy, but we've done that. We've had patients where we've coordinated. I'm in Los Angeles, so UCLA is a hospital nearby where we've had to coordinate with ophthalmologists to perform procedures that usually would be done just inpatient, but for patient safety have to be done in a hospital setting just to make sure they're more monitored. And same idea, like in my patients where they're younger adults, not seniors necessarily, but they need gurneys or they need medical transportation to get out for care, or they have mobility issues where they can't quite position into classic office settings. There's ophthalmologists that I've had to work really closely with to coordinate this care because it is still possible and it's doable and the patients really need it, but it definitely takes a little more planning, a little more coordination. There's oftentimes hospitals involved as well.
Switching gears to operational logistics, from a billing and coding standpoint, are there differences between your mobile model and standard brick and mortar practice? Do travel fees, location modifiers, or equipment transport logistics create complexities or opportunities that you didn't initially anticipate?
Yes, definitely. Actually, the biggest difference is that in my mobile practice, we no longer take insurances. It's probably the biggest change. So when I opened the practice, I had every intention of taking every insurance. There are billing nuances that are different for mobile care versus office care, different codes, different specifications you have to use. But at the end of the day, the amount of travel time wasn't feasible for me to work because I do a lot of concierge care and house calls. I'm in situations where even when I go into an assisted living, there might be 80 patients there, but I might be just coming to see one or two. So my practice personally is more house call style. And so the amount of driving I was doing between patients, especially in Los Angeles, nightmare traffic, it just wasn't working to keep the insurance model. So the mobile practice is no insurances. We do provide super bills. Patients are able to submit them themselves, but we don't bill any insurance.
I see. I think that's probably an added efficiency given the time you're on the road and time you're in each and every person's home because it is that very concierge style. Clock goes away. You're there for as long as it takes.
Exactly. And it often takes a lot longer than an office exam, as you can imagine.
Hmm.
And probably most of the time, I spend more time driving to and from the patient than during patient care. But that drive is part of patient care because they can't get out.
So let's address positioning in the profession. How would you position mobile eye care within optometry? Is it a full blown specialty or is it more of a niche or service line extension? And why do you see it that way?
I think it's a little bit of both. I think that optometry definitely has a really big opportunity here. I think there's a lot more mobile doctors on the East Coast from what I've noticed. The West Coast, not as much for some reason, but I think for optometry, this is a huge opportunity. And it's a way that we can be there for patients that goes outside of office care. Is it niche? Yes. Is it specialty? Also, yes. Tell you from experience hiring doctors, I can hire a doctor to work at the office and there's pretty much no onboarding. It's just here you go. This is the equipment, this is what you do. Everybody pre-tests for you and move on. When I've hired doctors to help me in the mobile setting, it's week-long trainings. It's a whole different paradigm of patient care. So definitely not something that we're all coming out of school with, to be honest.
So one of the things, as I've spoken to lots of optometrists and even had on the show, they talk about the future of optometry being like specialization, whether it's, specialty contact lenses or surgical optometry. Is this one of those areas where we can specialize? There was formal training and a
Absolutely.
designed area where you can develop someone's skills so they're not kind of just winging it on their own and learning from folks out in the field and on the job training?
Absolutely. Definitely. I think that there can be different skill sets that are trainable that can be applied to mobile care. And this probably goes across all specialties, but especially with eye care. We do have the tools, but the approach and the way you use them and little tips and tricks that we pick up along the way, it's definitely a whole different skill set than just primary care. Even though you pretty much are just, at the end of the day doing primary care, but the setting is so different than an office that it's a whole different set.
Next, some pragmatism. In your experience, where does the mobile model work best? Patient types, locations, scenarios. Conversely, are there settings or situations where mobile eye care is less successful or viable, and why?
So the conversation that I often have when I'm meeting nurses or caregivers or care teams when I go into assisted livings is always centered around the dementia patients, the memory care units. I'm happy to help anybody, but patients that can verbalize and explain what their issues are can often get more resources and better care.
Hmm.
The patients with dementia, I've really learned so much along the way. They won't complain. They won't come out and say, my glasses don't work anymore. They're blurry. What will happen is they'll disengage. And a lot of things, when you have dementia, get blamed on your dementia. So I've had conversations with families where I've told them, mom or dad doesn't understand how to use a progressive lens anymore, or a bifocal. I know that they've had it for so many years, but now there's dementia and it's confusing. And that's why dad keeps taking the glasses off. If anyone here's worn progressives, we all know day one is a little funky. So with dementia, every day's day one. They really don't do well in progressives or bifocals. I've had patients that we've done something as simple as take them out of that. They stop falling, fall risk goes down. I've had families call me and say, we thought that she stopped, feeding herself because of the dementia, but with her new glasses, she's feeding herself again. They won't say, I can't see the food in my plate. They'll just stop feeding themselves. They'll disengage.
What?
Those are the things that need us the most.
And you learn this, through the mobile model.
Yes.
There was a, I guess, a trend with these
Yeah.
similar patients with the dementia. And really, that is, I mean, first of all, it's sad that somebody wouldn't feed themselves just because they can't see the food on the plate. And the fact that you've kind of put two and two together and solved this problem, realize, you know what? Those progressives is a big no-no. Get rid of those. That's that's the kind of, I think, breakthroughs that I think what you're doing now is really going to make a big difference to a lot of folks listening. So let's talk gear a little bit. To deliver comprehensive eye exams at patients' homes, did you need to modify or select specific equipment, devices like portable autorefractors, handheld fundus cameras, etc., without disclosing any proprietary information or trade secrets? What innovations or adaptations have been critical to making the mobile model truly effective?
That's a really good question. A lot of people, when they actually reach out to us, will ask me if they hear mobile, but they go, "Are you in a van?" So there's a lot of mobile equipment that does still need a table setup,
Hmm.
and so that was my really big learning curve too. Is if I'm going to be mobile, for me, it has to be handheld. It has to be portable. If they can get into a van, they can usually get into an office. Sometimes I've been in patients' rooms where there is no table. So I can't be screwing a slit lamp onto a table if I don't have one. Definitely the toolbox is pretty wide with what I use. different things work better in different populations. But for me personally, I always make sure I can hold it and that it's portable. There's portable out of the office, and then there's bedside portable.
Looking ahead, what new technologies, whether portable imaging, teleoptometry, AI algorithms, do you see as a perfect fit for mobile eye care? And how are you incorporating or planning to incorporate them into Rad mobile eye care?
So technology is a huge, huge part of being able to do what we do. I love the advances that have come about in technology. Examples of things that I've bought in 2020. I used to have the tonometer that, one of my big complaints was always if patients were bedbound, it was harder. Now they make tonometers that you can be laying flat and you can still measure. The retinal cameras are now using AI technology to kind of help catch stuff. So technology is really what's making this easier and more doable, and I'm excited to see where it goes, especially with all the AI stuff. I will say that I think there's some pushback sometimes in healthcare overall to new technology, and especially with AI, it's kind of a controversial thing. In mobile healthcare, I think all the doctors doing it really do embrace the technology because it allows you to do what you do.
Mm-hmm. One of the things that, I mean, across the board, no matter what you're doing, whether it's brick and mortar, across all the different specialties, I think in our day-to-day lives, that if positioned as an instrument versus a crutch, that it can be very effective in adding efficiencies to your life. Some of the mundane things that are kind of like a time suck become a lot more easy. Obviously, AI can't just be on its own. You still have to check the algorithm and all this kind of thing because it can't think for itself. But certainly some of the day-to-day mundane things that I think that people can do, that you can spend time doing other things more valuable and have the AI and some of those other technologies take over is a distinct advantage. And in your situation, I think it really helps.
Absolutely. When I'm with patients, I'm both hands dedicated to the patient. Like a laptop, there's no chart, there's no computer. I'm just me and the patient. I'm holding equipment. I'm sometimes maneuvering the patient or the equipment in different ways. So for me, like being able to have an AI scribe or a virtual scribe, something like that has really changed that exam would take twice as long if I had to carry my computer around or a
Sure.
chart.
Or have an assistant, with you all the time just to
Yeah.
take notes.
Yeah.
So, a little bit of a business reality check here. From a financial perspective, how viable is the mobile model compared to a traditional office? Are margins tighter, higher, or just different? And what should a colleague considering this model know about the economics up front?
It's definitely an investment. The big investment is the equipment, especially if you want to have the bells and whistles. There are different ways to do this. You can do things a little more manually, but if you want to be more techy, kind of more advanced, the equipment is definitely an investment. And funny enough, the smaller it is, the more expensive it is. The retinal cameras that are portable, they cost more than the big ones in the office. So that's really the big investment is the equipment, taking care of it. The other limitation is that if there's multiple doctors working, you need multiple sets. It's not an office where you just have your one set. You know what I mean? Those are kind of the financial things to consider. It can definitely be rewarding financially, but really in all ways, but especially financially. And there's different ways to do it. There are models that should work in the insurance realm as well, but you have to have more corporate clinical accounts versus house call style. So, but yes, is the answer to the question.
So you mentioned constraints. It's important. I think it's important to recognize those. What limitations have you found in the mobile model, whether in patient volume, scope of service, regulatory challenges, or equipment logistics, and how have you addressed or overcome them?
Equipment is probably the big logistical hurdle because there is a lot. I mean, I'm walking in sometimes with a backpack, a rolly bag, little briefcase, like it's a lot of stuff. And so having another doctor on the team means a whole other set of equipment. In the office, you've got one set, and if you hire fill-in doctors, they work on your equipment when they're there. But if you have doctors covering different territories or different geographical areas, that's a set of equipment for every doctor. So that's really the big difference logistically.
So, since every great practice is powered by a great team, let's talk about the people behind the scenes. When it comes to mobile eye care, I suspect that staffing looks a little different than a traditional clinic. What roles are essential for your for the mobile model to run smoothly Do you need fewer people, different skill sets, or more logistical savvy team members? And how do you train your staff to deliver care in an environment that are always changing from one home to the next?
Yeah, it's definitely very different. I will tell you that almost my entire team, with the exception of my optician, is mobile, meaning there is no brick and mortar for the mobile office.
Makes
I do
sense.
have my office where patients can come in, but it's not an office where my team is. They're kind of spread out different places. By far, the most important role is having a really good appointment coordinator. It is so different than answering the phone and booking an appointment when it's an office, because our appointment books are coordinated by geography. We work different areas of town, different days. So knowing which patients are seen on which route, which routes overlap, which routes don't overlap, it's really quite complex.
Hmm.
So that's a very important role. I have a wonderful optician that we work with that's also mobile. So when
Wow.
patients
Okay.
get glasses, yeah, because what I realized too, when it's one thing if you have, a little bit of limitation with mobility or cognition, whatever it is, to just ship you glasses in a box that come to your home. But she's actually wonderful. She comes to the home's mobile optician and does the fitting. So the same way when you pick up glasses from an office, all those fitting and adjustments, that's provided as well. So definitely a different team. Some skill sets overlap. Having a fully virtual team is really the big difference.
So, I mean, you have the brick and mortar, but and obviously you have the mobile as well. What is the percentage of like where you dedicate your time and where you feel like is the main business?
It's really changed. When I started doing this in 2020, this kind of seemed like it was going to be a side gig. As I got more into it, I realized what a huge gap in care it is, and I really dived into it more. Today, I practice at the office maybe 2, 3 days a month. I have a wonderful doctor that's full time at the office, and fill in doctors that help. It's really quite easier to staff the office. In the mobile, I'm the main doctor, so I work 4 days a week usually doing the mobile care, and, that is harder to staff with doctors. Again, all goes back to the equipment, the skill sets, it's just a little more complex. But for me, I would say it's 90% mobile these days, 10% office.
Okay. Now, wisdom for the next generation. If an optometrist or new grad is intrigued by the idea of offering mobile eye care services, what would your top recommendation be? And what should they plan for, expect, or avoid to increase their chances of success?
So I think that part of mobile eye care is understanding your patient demographic is going to be completely different. This goes back to what you were saying with doctors specializing. When you become a dry eye specialist, you have a certain age group that tends to get more dry eye. Those become your classic patient. I think anyone going into mobile eye care needs to learn more about geriatrics in general. What are seniors like? What are elderly patients like? Not just eye care, but overall health. And there's just a different skill set to seeing patients like that. In the office, this probably varies, but I don't think most optometrists or ophthalmologists, um, maybe for ophthalmology it's different, but I wouldn't say 90% of any optometry office is patients 90 and over. Probably 80% of my mobile practice are patients age 80 and over.
Wow.
So
Okay.
having an understanding of a geriatric approach to the care is very important.
When you say geriatric, what's kind of like the broad range of ages? I mean, obviously they're in the geriatric category. Is it start at 60, 70, 80 on up to what?
My patients are over 80, I would say.
Oh, wow.
That,
Okay. So they're
yeah,
octogenarians then. Okay.
the age where now it's harder to get out. Now things start to change in your body that just mobility becomes a bigger issue.
So curious, I mean, you talk about patients who are older, have some memory challenges, dementia patients. When you show up multiple times to do like pressure checks and eye check, do they remember who you are? Or you have to reintroduce yourself again? Is that
Sometimes,
a
yes.
thing? It's just like, I mean, like she's got to
Yeah.
have to
Yeah.
reintroduce herself like every time she walks in. It's the same doctor.
Yeah. Yes, so for the memory care patients, it's usually you start fresh every time,
Wow.
but you have patients that are older, just not in memory care, and they do remember, and you build special relationships with those patients.
So, a forward looking question for you. How do you see AI playing a role in supporting mobile eye care, whether in diagnostics, patient triage, workflow automation, or even remote monitoring? And are you seeing it now or planning to? And again, you kind of touched on it earlier when we had an AI related question, but maybe you can expand on that with this one.
I think AI is going to play a very big role in all healthcare as we move forward, especially when it comes to mobile care. I have seen remote patient monitoring becoming more of a thing. For example, monitoring pressures and having AI kind of pin the ones that are outside of your target ranges. What I use AI for every day that I love is I scribe my exam. A lot of the times the patients that I see, there's caregivers involved, sons, daughters, nurses. So by the time I'm done with that exam, there's a summary that goes out to the patient's son or the patient's daughter. And it's just such a time saver. I think that's really the main thing with AI is if you use it properly, it can save so much of your time to do things that AI can't do. AI is not drive to my patient's house and give them an eye exam, but I can do more of that if AI does my notes and my charts for me, or at least the bulk of it.
So, before we take our final off ramp, I want to touch on something just as important as clinical care, and that's visibility. Your branding is bold, memorable, and unmistakably rad. How intentional has that been for you, and how do you approach your online presence, whether it's social media, your website, or digital content, to help patients discover rad mobile eye care? And what have you found to be the most effective ways patients are finding you today?
So a lot of patients find us online, so definitely the online presence matters. What I'm learning, and actually a big goal for me, is to actually get more involved in kind of doing social media and things like that, because I think there's an education piece that is really important to share. What the mistake that I made is that I assumed that because my patients are older, they're probably not online as much, and I was looking into avenues to increase visibility. But what I'm realizing is a lot of them are finding me through their adult children. So it's their kids helping them find the care, and the kids are online. And so I think kind of getting online more, educating more, having patients understand that there the barriers that they thought were present for mom getting an eye exam, like transportation or, special needs, they're not really barriers, and we can still help.
So, and now for maybe something a little more fun. Finally, you're widely known for your nickname, Dr. Rad. How did that evolve? And did you build a brand or theme around it? And does it reflect a particular philosophy or vibe that you bring into your practice in mobile service?
Yes. So obviously play on words, it's rad. And it kind of came up. So Radzinski is the full last name. And it's kind of a mouthful. So when I graduated, I was actually Dr. Pitchcar. After I got married, I was Dr. Radzinsky. And as soon as I came to the office with the new last name, my colleagues were just like, Dr. Rad, just day one. And I carried it with me. And the funny thing is, a lot of, again, my patients being older, that's their lingo. So they
Yeah,
love it.
yeah, totally.
Yeah.
It was meant to be. It was meant to be.
Yeah, exactly. So works well.
Well, Dr. Rad, this has been an absolute pleasure. What you've built isn't just a practice, it's a movement. Your courage to step outside the traditional walls of eye care, your entrepreneurial spirit, and your commitment to meeting patients exactly where they are is nothing short of inspiring. You've taken a model that many people in eye care only talk about, and you've turned it into a thriving, impactful reality. Before we wrap up, I'd love for you to share to some of our listeners that may want to keep the conversation going with you, whether someone is curious about starting their own mobile service, wants your insights on the business side, or simply wants to learn more about Rad Mobile Eye Care. What's the best way for them to reach you, follow your work, or connect with you online?
Absolutely. We do have a website. It's radeyesmobile.com. And I am on Instagram, Facebook. Our Facebook is the same, Rad Eyes Mobile, Instagram as well. And all of these are linked on the website. And like I mentioned, plan to get a little more involved with our social media. So I would love to connect with patients, or if there's listeners out there that are thinking, my mom could use a mobile eye exam, we're here. I'm here to help.
Awesome. Well, thanks for sharing that. That'll be valuable. So as always, folks, I'd like to thank Riverside FM and Passionate Media for making this show happen. And of course, our benefactors, Meridian Medical Lasers, for making it all possible. And everybody should know by now that the Q-Switch Conversations podcast is my way of giving back to an eye care industry and community that's truly shaped my career, my perspective, and my passion for what we do. This platform is truly built for you, the clinicians, the innovators, and change makers redefining what's possible in our field. So if you've got a fresh perspective, a unique experience, or know someone doing great things in eye care, I'd love to feature them on this very show. You can hit me up on LinkedIn or drop me a line at d.spence@meridian.ch. That's a wrap for this episode of the Q-Switch Conversations podcast. I'm Spence, and I am out.
You're listening to The Q-Switch with your host, Spence.